Arthrocentesis, or joint aspiration, is an important diagnostic and therapeutic procedure for the emergency department. It may help differentiate the etiology of a joint effusion and may provide symptomatic relief or assist therapy by removing offending material from the joint space. Indications for arthrocentesis include any joint for which removal of joint fluid would enable you to diagnose a joint infection, inflammatory arthritis, acute fracture, or to relieve the pain of a large effusion. A similar approach may be used for injection of a local anesthetic or anti-inflammatory medication. Relative contraindications include disruption of the skin or the presence of a skin infection overlying the area where the needle would be placed, as this may increase the risk of introducing infection into the joint space. Presence of a coagulopathy is also a consideration, as it may increase bleeding within the joint. The procedure should be performed with sterile technique. Equipment needed for the procedure includes clean gloves, gauze squares, chlorhexidine solution, sterile drape, local anesthetic, a 25 to 27 gauge needle with a 5 cc syringe for anesthetic injection, an 18 or 20 gauge needle with a large syringe to aspirate fluid, specimen or culture tubes, and ultrasound with sterile probe cover if real-time ultrasound visualization is planned. For illustration purposes, sterile drape and probe cover will be omitted. An LP needle can be used for aspiration if the patient has extensive soft tissue. The patient should be placed supine and the affected joint should be thoroughly inspected for signs of infection. The procedure may be performed with the knee in extension or slight flexion. We will demonstrate the technique in full extension, which allows for relaxation of the quadriceps tendon. The joint space of the knee can be accessed through several approaches, including medial or lateral suprapatellar, parapatellar, or infrapatellar. Palpate the knee to identify landmarks, locating the patella, distal femur, and the tibial plateau. Patella, distal femur, tibial plateau. Ultrasound will help to visualize the joint space and confirm the presence of an effusion. It can also help determine which approach to use by locating the largest and most easily accessible fluid collection. A high-frequency linear array transducer should be used. Place the ultrasound probe over multiple potential aspiration sites to confirm effusion and determine the best approach by which site has the most easily accessible fluid collection. This probe is placed over the lateral parapatellar space with the probe marker placed towards the head. This is an image of the same parapatellar space with a large effusion with the distal femur and the edge of the patella highlighted. Prepare the aspiration site using sterile technique. Inject local anesthetic superficially, avoiding injection into the joint space. If infection is suspected, introduction of anesthetic may cause false negative culture results. Place the ultrasound probe so the target area is visible. Line up the ultrasound and needle so you will visualize your needle in plane. Direct the needle toward the effusion and visualize aspiration. Aspirate as much fluid as needed for diagnosis or symptomatic relief. Remove the needle and place a clean dressing.